so I get so fast. Okay. So this is about, and Dr. Chinn and I have been working on this for a while, this is about reducing the catheter-associated urinary tract infections, and everybody has a different skill set with putting in Foley's. Most of the research nurses are obviously on 6North because that's where most of the urology nurses go. So we're trying to, from the get-go, which is the insertion of the catheter, do everything we can not to get infections. And I think this is a really important step. This is your first and best chance to prevent an infection. If you contaminate the bladder here, then no matter what you do after that, you have an infected bladder by definition. You may or may not see it clinically because you may or may not have the patient on antibiotics because you have an infection. You know, and there's an urban myth that urine is dirty and it's sterile and the bladder is sterile. So I like to use this metaphor of there's the sterile world and the non-sterile world. The bladder is in the sterile world. And then that metaphor applies to the nurse team, which is the person who inserts the catheter and the person who I would call the circulator, who hands things into the sterile world, which is exactly what we do in the operating room. So there are a couple other myths I wanted to dispel. There's a fear of this lidocaine jelly, and it's kind of an institutionalized fear, and I don't know if it's because it has lidocaine in it or because it has kind of a wicked-looking delivery device that looks like a code syringe, but it's absolutely harmless. You could swallow this stuff. You won't find a measurable lidocaine level in your serum if you swallow it, probably. It'll never hurt anybody. You'll never overdose anybody. If you're doing intermittent catheterization, and Ray and I had talked about this, you're not going to overwhelm somebody with lidocaine. When I use these in the office, I use 3 or 4 of them. There are some settings where we might not want to do that if you have a fresh prostate that we've just operated on, but that's a little different, and that's not the usual patient that you're going to see. A couple other things I just wanted to mention. The catheters don't get inflated until you reach this Y. And I know in some nursing schools, they teach you to test the balloon, which doesn't serve much function. These balloons really don't fail. And they also teach you to inflate the balloon as soon as you see urine. So in the male patient, who can tell me in the male patient when you probably see urine from the end of the penis to the bladder? At what point do you think you see urine?
Almost in the Y.
Almost in the bladder, which is where?
Like almost in the Y of the
Oh,
catheter.
almost to the Y. But in the anatomy of the tip of the penis to the, from here to here, where do you think you'll start to see urine when you put this catheter in?
Maybe the way.
Yeah, in the urethra, right about the where? The prostatic urethra. So what happens, you blow the balloon up in the prostatic urethra. And I think that's what happened to these simulators, because we used them yesterday, and they're all catching. These patients have strictures, both of them. So we just wanted to know. I'm glad we knew yesterday instead of this morning, because they're kind of difficult to use. But it even says on the box for these things, wherever it is, it says don't blow the balloon up until you have the catheter all the way in, which is a great teaching device, but it also says they'll break, and they did break. Couple other things. Irrigation, and I've seen kind of variations of this on the floor. The irrigation we only do with a piston tip syringe, not with a bulb turkey baster thing. It just doesn't work. It just doesn't work. It's crummy. And it's sterile. So all this stuff is sterile. And if you just keep in mind that the interior of the bladder is sterile and you can't violate it. So that kind of covers, it's a concept that I want you guys, because you guys are the stewards of asepsis on the ward, right? This is your responsibility, and it's very serious responsibility, and there's an honor system with sterility, and you always have to check yourself and say, did I touch this? Did I contaminate myself? Can I use that irrigation syringe that the other nurse said was okay because it's sitting on a table and I don't see that it's in a sterile world, it's in some other world, a contaminated world.
So every time we irrigate, we need a new piston.
You should, yeah, unless you have a way of keeping that one sterile, and it's very difficult. Does everybody here know their size of surgical glove, surgical sterile glove?
Yeah.
I think maybe not everybody knows. Do you guys wear them?
Yeah.
The real ones?
Yes.
Okay. All right. You all have easy access to them?
Yeah.
Okay. How many glove changes do you think it would take on average for somebody to put a catheter in sterilely by themselves and stay on, not close to sterile, but absolutely sterile? 3 minimum. I challenge you to do it. I challenge you to do it with 3. 4 is more likely if you think of all the steps that you have to do. So we have a little mnemonic. I'll talk to you about it after Ray and Courtney go through this. It's a mnemonic for the ordering of what you need to do. And I think that one of the very most important things is to come up with your own mnemonic so that when you say, I have to go and put a catheter in, I have a system and I've got an order of doing things and I have all of my equipment so that circulator can pass me stuff so there's no drama. So you don't have a patient who's in some agony while you're trying to do something and now you need something and she has to run out and you have to take your gloves off and now you don't know it, but when you leave the room, the patient alters the sterile field and now we're contaminated. So, questions about anything?
I have a couple of questions.
Sure.
The lidocaine is not part of our
Right.
order set, to my
We
knowledge.
need to change it. We worked on that a couple of years ago. We need to change that. It needs to be absolutely easy for you guys to use.
And what about the importance of checking if the patient has had Exparel? Would this affect?
It's a good question.
So I
According
spoke
to
to the head of pharmacy, and they said that the only way that having Exparel and lidocaine would affect you was if you were to take the lidocaine jelly and put it exactly where the Exparel was injected during operation. And what that does is it speeds up the bupivacaine spreading through the system. So say you had someone who had belly surgery and they injected it subcutaneously in their abdomen, they would have to put the lidocaine jelly on that spot in the belly for it to speed up the release.
So we're okay with it?
We're
Yeah, you're okay. You're not going to hurt anybody with that lidocaine. If you put that lidocaine in somebody and something happens, it's something else.
Okay.
It's not. And these are absolutely sterile. So this is integrated into the putting catheters in. They're great because they lubricate the urethra and they dilate the urethra. And just a little nuance on these. On the male patients, after you inject, you want to inject with a fair amount of force because you want it to go all the way up to the sphincter, because that's what you want to anesthetize, and that's where the male patient fights you before you even get to the prostate. You
The
squeeze-
entire Uro-Jet?
The whole thing. And if necessary, and have another one ready,
Wow.
if necessary, yeah. The whole thing, and you hold it, and I'll just give you a number arbitrarily, 1 minute, we'll do it. That's after your sterile prep. You treat this just like you would treat the catheter, absolutely sterile. And that will make your job a lot easier.
It also, this is also used for intermittent cath.
Yes, use it for intermittent cath.
But the other thing is that we're trying to, after we get clarification of the risk of lidocaine, we're going to actually embed it into the Foley insertion and also in the intermittent cath protocol.
Yeah,
That would be
exactly.
awesome,
Yeah,
because
that's
I think
what
that's the
Deb wants.
stumbling block for
It
many
is,
nurses
yeah.
using it.
It is a
It's another
stumbling
call
block.
to the doctor.
It is a stumbling block. Yeah, we want you to be easy with that so that it's not. There's another on the cart. There's another form of this. You guys have seen it in the red and white tube, the steel tube, the aluminum tube. We need to take it off. It serves absolutely no purpose.
No.
It's
I
a
mean the
non.
gel?
Yeah, it's
Oh,
a
yeah.
non-sterile.
Yeah, and also it's multi-use.
Yeah, it's multi-use. So you use a little bit of it here and you use a little there, and then you spread E. coli around everywhere. So.
And it will be less of a culture change on 6North because it's actually stocked in our Pyxis, so it can be overrode and then you can get the order from the physician, but it's there for you. On the other floors, it will be a little bit of a change because we'll need to get that stocked on the floors. Otherwise, pharmacy would have to tube it up to you.
I don't know if you guys have noticed, like you call a urologist and he's grumpy and nasty, but he comes in. But he's quiet like me. He's just grumpy. So on the way in, I always try to call and say, can you give the patient some pain medicine? And then I stop in the operating room and I steal this stuff because it's hard for us to get. They've got it's a ridiculous concept. They have this stuff like it has street value. It's just lidocaine jelly. You can put that in a GI cocktail, basically. So I come upstairs with this, and that's the scenario where then the urologist gets here, looks like a hero because the urologist just injects this, dilation, good anesthesia, patient's relaxed, catheter goes in, right? Then you guys then you don't have to make the call. That's the key for these guys to do there. Yes.
So we inject the
Yes.
how long do we?
A minute. I mean, it can be, and with the female patient, the way I didn't mention this, the way you hold it in with the female patient is you just hold it there.
Okay.
Just hold it in the urethra after you inject it.
And then we just
Yeah, just squeeze the end of the, we'll put the whole thing in the female patient too. and then just hold that against the meatus. So I'll see. All right. So yeah, just hold it against the meatus, and then have another one ready. And your person is taking care of all this stuff for you, so you don't have a bunch of drama. And that's what the pain medicine is for. If you have pain medicine orders for the patient, this is a good time to get it. Sometimes if a patient's not on antibiotics, I'll say, and Ray probably shouldn't do this, but I'll say, give the patient a gram of Ansa. So, but we do that in the office. I'll have to talk to him more about that. That's probably not a good practice. But that's kind of the preparatory stuff, so that it goes easily for you. Bed's at the right height. You got your gloves. You got extra gloves, so that when you touch something, you can just put the gloves on and get it all done really quickly, instead of just like hurrying around.
Is the reason to keep the tip at the urethra for the female just to keep the jet flowing?
Yeah, and then keep you kind of away with you have your left prepping hand or right hand. I think we're kind of sticking with that, right? The left hand stays up and retracts the labia. So you don't have to use that hand. You can actually just inject it and just hold it there. And it'll spill out a lot of it. Who cares? Who cares? Are you guys comfortable with irrigation with the piston tip syringes? It's scary sometimes because you don't know if you're going to explode their bladder. Okay. So yeah, and we understand that. And you have to remember that when there's a catheter in and the bladder is relatively empty of urine, maybe not blood, that the catheter is sitting up against the mucosa of the bladder. So if you put in just a little bit of irrigant saline and you pull back, you suck that catheter against the mucosa, and you feel it because it just stops, right? So you have to put in a little bit more, and when you'll develop this feel, and I know all of you have done this, where if you kind of put the in and out with the piston, then you go, okay, this is good. And when you call the urologist and say, I had to do this or that, she'll always say, did you irrigate the bladder? Not to know that you necessarily got the stuff out. They want to know that the catheter is in. That's the reason for that. Not maybe in, but in. Then you know and you're confident. You say, okay, I put a catheter in this patient. I tugged it back to the bladder neck. I irrigated it. What goes in comes out. It's in.
You know, when you irrigate, what are some of the common reasons for contaminating the system when you're doing it?
I think everything from A to Z, you're reusing a piston tip syringe that's been sitting on this scan. And I wanted to ask you that about, I know that we've changed some of thinking about disconnecting the tubing from the Foley. Sometimes you'll see people disconnect the tubing, and the tubing is just lying in the bed, contaminated.
Right.
Or there's no prep of the outside. I usually, and I don't know if this is right, I usually use a little betadine on it. Yeah, and then I set it down. That's what, can we bring some sterile towels?
I have drapes.
Like green towels?
What do you mean?
We talked about this yesterday, and we're using the green, nice, sterile.
So they don't have them, it's only in the OR.
The ones you take home and use it to wash your car with.
Yeah. They can't stock it on our floor, so.
It's a vendor that stocks the OR, is not a supplier for the hospital, so
Okay.
they come in and keep the OR supplied,
Okay,
but they wouldn't be able to do our
we
floor.
can work on that. We can change that.
Are
Those
there
green heavy
sterile,
towels.
that's not cloth, that are disposable?
Yeah.
Can we use like the ball?
Well, so we have
Okay, so let me ask you, what would you want, what's bad about the disposable ones?
Like that,
Yeah,
when they get wet.
right, and what else? A breeze comes in the room and they fly off the patient.
Oh,
They're not a stable, sterile platform.
That's good.
You want to create, she wants to have a little operating table here so that she can put stuff down. They're horrible. I mean, I've never used them for central lines, chest tubes, or anything. They're horrible. They just move all over the place. You've got your area prepped, and you look at the patient goes like this, and they move. So in theory, they're good. The ones in the operating room tape down. I don't think these do, right?
No.
They have a tape down on them, so you can tape them down onto the patient, but they're still kind of crummy. But the cloth ones are heavy, and they'll stay put. And then you can lay them out. So I think that would really help a lot.
I suppose we could look into some of the stickies,
We could do that, yeah.
and just to see.
That would be kind of cool. If we had like a big one with a hole,
Yeah.
and we could put the hole, to cover the perineum. So that there's no contamination when you're doing the prep.
But you're talking about for irrigating right now, right?
I'm talking about putting catheters in. I'm talking about for everything. That's why you'll see us when we bring the cart up in the bottom. You'll always see us do that. We'll go to this, I always put sterile towels here because I'm going to dilate sometimes, and then I put them all over the patient.
This doesn't have barrier enough, you're saying, because it could fly off the paper.
Yeah, it's cool, it looks good, and I get it, but it's, I mean, it's good enough, but we can do a lot better than that. If we're really serious about doing this, and this is the first and best chance. I mean, if we don't do this one right, then we're chasing ourselves the whole rest of the hospitalization, hoping that the ANSAF or the Rosafen or whatever it is that you give the patient is going to get the bacteria that you put in them. And that bacteria, we might be lucky, it might be home bacteria, it might be Ray Chinn's bacteria. That's the bad stuff. Right.
How about a carry?
Yeah, he doesn't carry it. It might be, and he's done a huge, like with C. difficile, a huge kind of breakthrough that he did was recognizing that this stuff is in the rooms and that we're giving it to the patients. And, right? And so if patients here for a couple of days, I'm sure Ray knows the rates of conversion of pathogens, but now we're giving them our super resistant, what UCLA calls a super bug.
Within that time, yes. But, the insertion piece, I think it goes through the entire catheter process.
Yeah, it does.
And depending on the type of organism and whether your immune system is good or not, will determine how long it takes for you to get the infection after insertion. But I think insertion is a critical piece.
Yeah, I do too. I mean, in the operating room, you contaminate in the beginning, it's on, you got an infection. You use a contaminated instrument on a patient, that patient's infected. I don't care what you do after, and I don't care how well you maintain these catheters after. You get this bug in the bladder, it's in the sterile world, it doesn't belong there, it's a pathogen, you've got an infection. Whether or not we're going to see it clinically is another issue, and how soon we're going to see it is another issue. It's kind of hard to know too by the timing, but. And sometimes these guys have to do really difficult ones, you have to be creative, and you just cannot maintain absolute sterility because you've got an orthopedic patient who's in a weird, awkward position. And that's where maybe you need a third person to help them. But this is really critical.
So I think Ray and I will start, unless does anyone have any more questions right now for?
So it needs to be a two-person job then?
It
Yeah.
It hasn't been.
It does.
So for males, it needs to be a minimum of 2, and then females, you have to take into account the size of the patient, the positioning of the patient. There's a little more that goes into it to keep that area sterile. So males 2, and then females at least 2, but depending on the patient's situation, you need 3, maybe a 4th person.